Uh, Good morning to many African countries specialists, and also good afternoon to Korean participants. My name is Young-Sung Lee, Director of Board of Committee of Korean Society of Medical Informatics. I can see some familiar faces include today's presenters, and also a new one, many new ones from African countries. This emergency seminar has been held by the request from many institutions and many countries. And you know, the current situation of the COVID-19 world crisis. The meeting was made possible thanks to the participants of specialists from many areas. These specialists include IT experts, also included under the KOHI staff, and the clinician groups, and the national institutes. Also, KOHI is one of the national institutes under the Ministry of Health and Welfare, which is specialized to education the medical staffs. From the beginning, I was interested in defining the current situation of the society of national crisis through important meetings with experts from many areas and look for the best solutions. I am expecting that this meeting will be productive to the current situation under the COVID-19. And also I express my gratitude and support to many organizations of this event, such as include the KOHI for supporting this seminar, and also co-host, and you know, the KISTI, which is the main focus to support all the IT solution under the Ministry of Science, and many hospitals, and also MedRIC Information Center. I am today here on behalf of the Korean Society of Medical Informatics. I would like to welcome each of you. I've heard 38 participants in this seminar from 18 countries all over the world today. This seminar is prepared to share clinical experience and information on COVID-19 in Korea for strengthening professional competence in healthcare by cooperation among several prominent Korean organizations. MedRIC, I say again, KOHI, KOSMI, KISTI, KSEPI, and the Chungbuk National University Hospital, and the Sun천향 Hospital. I wish you a very useful and meaningful time for everyone. Well, let us start our seminar to overcome this global health issue. I hope we will meet via offline sometime soon after this pandemic. Thank you again for having me here. I will now pass on to our moderator. Thank you, Professor Jinaki. Thank you.
Thank you so much, Professor Lee. And now we will go to the informative section of this web seminar. There are 3 presentations which are prepared. And the first one is a clinical course and the imaging of COVID-19 patients. And the second one will be COVID-19 as a public health crisis and response strategies in Korea. And the last one is the current issues of COVID-19 in Korea. Now I will invite the first presenter, Professor Jung Hae-won. And she also was an important person for the MERS outbreak in our country, and now she is treating the COVID-19 patients in 충북 National University Hospital. So let's meet her. Okay. we've already passed some questions from the participants to her. So when you listen to her, you can get answers from her within her lecture.
Hello everyone. The title of my lecture is Clinical Course and Imaging of COVID-19 Patients. Actually, until now, we had 4 coronaviruses which could infect human beings. In addition, we found 2 more beta coronaviruses, SARS and MERS. And in 2019, another coronavirus, SARS-CoV-2, were found to infect humans. These alpha coronaviruses usually cause very mild upper respiratory tract infection. However, these ones can cause severe and fatal infection. This is the situation report by WHO. We have more than 2 million confirmed cases and more than 100,000 deaths globally. It is occurring all around the world, and usually the transmission route is through the droplet. In direct droplet transmission, the droplet more than 5 micrometer size can usually reach 2 to 3 meters from the infected person. But using the indirect transmission, it can contaminate the surroundings of the patient, and by the fomite transmission, we can also infect other people. We can find some articles about suggesting other transmission routes. Actually, the RNA of SARS-CoV-2 was found in stools and urines and saliva, also suggesting the possibility of transmission of this virus. And actually in saliva, the live virus was isolated. So it is a kind of transmission route also. Actually, the main problem is the viral shedding. It is found that asymptomatic and pre-symptomatic patients shed virus. Viral RNA was detected usually 1 to 2 days before symptom onset. And some patients continue to shed the virus after the clearance of their clinical symptoms during their recovery phase. In Korea, we isolate the patient until we get 2 consecutive negative RT-PCR in respiratory specimens. So usually it takes more than 3 weeks of the isolation period. And usually in the later phase, the patient don't have clinical symptoms and just they shed virus, which is detected by RT-PCR. This is the summary of an article produced by the Chinese CDC. According to this article, the incubation period is usually 5 to 6 days. They provide the clinical severity. 80%, about 80% was mild. 5 case was without pneumonia or very mild pneumonia. And 14% of the case was severe pneumonia with dyspnea, respiratory rate more than 30 per minute. Blood oxygen saturation was less than 93%. And actually the patient has acute lung injury profile, and in X-ray or CT, more than 50% of the lung was involved. It was considered severe. And 5% of them developed respiratory failure, septic shock, multiple organ dysfunction, or failure. Case fatality rate was about 2.3%, but it was very different according to the patient age. More than 10% of the aged patients were fatal. And if the patient becomes critical, about 50% of them die. Actually, many audience actually requested some data about the asymptomatic infection before this seminar. However, the asymptomatic infection rate is very different from country to country, because it depends on the epidemiologic investigation and mass spreading events. If the government rigorously investigate the contact, more and more asymptomatic cases are diagnosed. According to an article which studied cases only in China, 75% of the patients diagnosed in their asymptomatic phase actually developed symptoms. So 1 to 3 of them remained asymptomatic. So actually, true asymptomatic infection is very rare, and usually the virus starts shedding just 1 to 2 days before the symptom onset. This is a summary of clinical characteristics of the study patients published in NJM by the Chinese group. Their median age was 47 years old, and the main symptom was cough and fatigue and sputum production. And about 10% presented with sore throat and myalgia or arthralgia. And their diarrhea and nausea vomiting was also reported. This is the summary of their radiology findings, and I will show you the findings in later slides. So their common symptoms was fever. More than 40% had fever on their admission, and 88% developed fever during their hospitalization. Cough was found in 67%, and sputum was found in 33%. Shortness of breath and sore throat was about this. And also they have 15 of them had myalgia or arthralgia, nausea, vomiting, diarrhea. For the diagnosis, currently the gold standard may be the PCR based, with real-time reverse transcription PCR. The target gene is very different in many countries. And for the treatment, no definite antiviral treatment was established yet. So supportive care is very important. So oxygen supply and intensive care is very important. And I will show you some clinical trial data about lopinavir with ritonavir, hydroxychloroquine, remdesivir, and favipiravir. This is an article about the data of the clinical trial of lopinavir and ritonavir in adult severe COVID-19 patients. Actually, they enrolled 199 laboratory confirmed severe SARS-CoV infection patients. About half of them were enrolled in lopinavir ritonavir group, and the other just got standard care. Mortality at 28 days was 19.2% in collateral group and 25% in standard care group. And also said that there was no clinical, no significant difference in two groups. But in a modified intention to treat analysis, collateral led to a median time to clinical improvement 1 day shorter than the standard care group. But the clinical, the confidence interval was like this, so it was not significant. But I think if we just continue to study this with more patients, we can get more exact results. And actually, the hydroxychloroquine or chloroquine is an antimalarial agent, but their antiviral activity was studied before this outbreak. And actually, in vitro antiviral activity, they found that hydroxychloroquine can be used as a treatment of SARS-CoV-2. And actually, another article suggested that their function in chloroquine can inhibit autophagic flux by decreasing autophagosome-lysosome fusion. So hydroxychloroquine and chloroquine changes the pH of the endosome and lysosome, so they have some antiviral activity. Also, they changes the important receptor ACE2 and glycosylation of the spike protein. So many scientists suggest this as the therapy. However, in some breakthrough report of the chloroquine phosphate clinical trial showed that in interim analysis, they showed some effect in preventing pneumonia aggravation, shortness of disease course in viral shedding period, but it was not significantly different. So actually this trial is just ongoing, and many physicians and scientists are waiting the results. And this case was about the first case treated in the United States. And actually they used remdesivir in compassionate use to the patient. After the compassionate use of remdesivir to this patient, there are currently many other clinical trials of using remdesivir to COVID-19. This is an antiviral agent designed for Ebola virus. And actually they can inhibit some RNA polymerase, so they can show some in vitro activity to SARS-CoV-2. Actually, this '73-year-old male patient developed fatigue, febrile sense, and 1 day later, he was diagnosed as SARS-CoV-2 with a respiratory tract PCR. The next day, the patient was hospitalized to another hospital, and after 4 days, he was transferred to CBMUH due to high fever and dyspnea. This is the chest X-ray in another hospital. And this is the X-ray we took to the patient. Simple X-ray, ground glass appearance started to be shown in both lungfish. We treated the patient with cholesterol, and the patient had fever, continuous fever, and we started to combine the inhaling steroid treatment and hydroxychloroquine. After a few days, the patient became afebrile and covered. This is the laboratory result of the patient. His creatinine was a little elevated, and actually the CRP level was very high. He had high level of LDH and high level of DIC profile. This is the CT scan of the patient on hospital day 4 and 12. The ground glass appearance just changed, and usually the subpleural lung was involved, and the VGO changed to the some consolidation and band-like lesion. We found that the COVID-19 is different from other viral infections. They have very high CRP level and high LDH, CPK, and very frequent DIC profile. Usually the patient develop pneumonia after 7 to 9 days of the symptom onset. And usually the recovery occurs after 2 to 3 weeks. And adequate supportive care with oxygen supply is very important. Let me show you some imaging finding of the COVID-19 patients. This is the study by Bang and KOHI, published in Radiology Journal. The title was Sensitivity of Chastity for COVID-19. They compared it to the RT-PCR. It was a retrospective study, and they included patients with a travel or residential history in Wuhan, or some contact history with fever or respiratory symptom patients. And actually they included patients who had fever or acute respiratory symptoms of unknown cause. The detection rate of COVID-19 infection based on the initial chastity and RT-PCR was compared. They included 51 patients, and actually the RT-PCR and CT was performed before or after the 3 days of the enrollment. It was found that just 36 patients from the 51 enrolled had initial positive RT-PCR. The negative patients just had some repeated PCR, and finally they are diagnosed, but the initial PCR was not 100% positive. But 89% of them had evidence of abnormal CT compatible with viral pneumonia at baseline. 72% showed typical pattern and 28 had some atypical manifestation. So they say that the chest CT can be a sensitive tool to detect some possible COVID-19 patients. These are the example of the typical CT finding. The visual A shows some bilateral subpleural ground glass opacity, A and B. B shows that the ground glass appears opacities and some consolidations. So C is the minimal GGO. This is a typical pattern of the early patient. And in D patients, the peripheral consolidation, subpleural area, peripheral consolidation is a typical finding. Also said that these are atypical findings. They describe some central lobe ground glass opacity here and small peripheral linear opacities in this CT. And in C, the GGO in central left to lower lobe here. And in D, linear opacity in left to lower lateral medial. These are some atypical presentation of the chest CT scan. Another group reported chest CT findings in COVID-19 relationship to duration of the infection. They analyzed more than 120 symptomatic COVID-19 patient CT in relation to the time between symptom onset and the initial CT scan. Early stage was defined as the 0 to 2 days from the symptom onset. Intermediate was 3 to 5 days from the symptom onset. And late phase was the 6 to 12 days from symptom onset. 56 of the early patients had a normal CT. So in early phase, more than half of the patients have normal chest CT scan. With a longer time after symptom onset, CT findings are more frequent, including consolidation, bilateral and peripheral disease, greater total lung involvement, viewing opacities, and crazy fading pattern and reverse halo sign, like this. It's GGOs, and usually the subpleural involvement, and patchy consolidations. Right middle lobe and left lower lobe. These are some late time CT, the subpleural consolidation and crazy fading pattern. This is actually the question I got before this seminar, and usually I can mention some of them. I think that just repeating CT is not so not necessary just for the diagnosis, but we can use it to follow the patient. Actually, thoracic ultrasound is a quite recent modalities, usually performed in ICU. So, yeah, its usage in COVID-19 is not established, but many intensivists are trying to accumulate the data of thoracic ultrasound because it is very convenient and easily accessible in ICU. Symptoms and signs are just presented before, and oxygen is very important. In older age group, they are more likely to be beta in case, and usually the comorbid conditions are risk factor for the fatality or critical manifestation. PCR positive and no clinical signs usually occurs in the pre-symptomatic phase and recovery phase. First phase positive rate are not established because we should know some patient, real patient pool to find this rate. Actually, there are some very famous articles in NEJM showing the 6-hour viable virus in the air, but I think the main transmission route is just droplet, that air. Case management should be done supportively. This ventilation or not ventilation, intubate early or late, it depends on the patient condition and the ventilator availability. In the lack of the ventilator, usually we use nasal high flow oxygen supplier, and I think compared to the CPAP or BiPAP non-invasive ventilator, high flow oxygen therapy even much better. This is the internet providing Korean guideline, but it is in Korean. So usually in English, CDC guidelines and WHO guidelines are very helpful. Thank you for your attention.
Thank you so much. Let's thank her with a big applause. And I was to ask her the number 10 question, how can we detect the asymptomatic cases in low-setting resources? But within her presentation and also at the end of her presentation, I think that she covered it in some degree, so we don't need to ask her more questions. Thank you so much. And the next presenter is Professor Kim Dong-hyun, and he is the president of Korea Society of Epidemiology, and he will make a presentation. Its theme is COVID-19 as a public health crisis and response strategy in Korea. Let's meet him.
Okay, is it okay to start my presentation?
Yeah.
Right now? Okay, thank you for your nice introduction. Hi everyone, I'm Dong-hyun Kim. I'm working for Hallym University College of Medicine as an epidemiology professor. Today I'm going to talk about the COVID-19 as a public health crisis and the response strategy in Korea. This slide shows the content of my talk. I'm going to cover the epidemiologic pattern of COVID-19. Of COVID-19 cases are reported to be around 2.5 million worldwide and 170,000 deaths. As you see in this slide, in February, most of cases appears to occur in China, and then cases from Europe start to increase, and then And then the cases from the United States started to increase sharply. This slide shows the new daily confirmed cases after the first 30 cases reported from each country. As you see, epidemic curve started to bend in some countries, such as Ireland, Australia, Norway, and Austria, including South Korea. But the epidemic curve of the United States and the United Kingdom, Italy appears to still approaching the peak of this epidemic. This slide is about the number of deaths in some countries, which generally increase with time, but the number of deaths in Korea is far below 10 per day. But the number of deaths in many countries still increasing. This slide shows the case fatality rate of some countries, which is widely varying. In the figure, the figure in the right side shows the trend of the case fatality rate. As you can see, the case fatality rate, which is one good index of the severity of this epidemic, and we can compare how the healthcare capacity is coping this disease in each country. The rate, case fatality rate of United Kingdom and Italy is persisted to increase up to now, but the rate in Germany and in South Korea steadily, slowly increasing. So the case fatality can be compared among countries. So we can there may be some some factors affecting case fatality rate due to COVID-19. There may be differences in countries' surveillance strategies, including testing capacity, and then also there may be differences in healthcare response capacity for critically ill patients of each country, and there are also the accuracy of reporting deaths related with COVID-19 is different according to country, and then age structure of a confirmed case may not be same. The median age of the confirmed cases may be different country by country. And finally, there are expected to delay of a clinical point in some point which reported the death. As almost 4 months have passed, we became to know some of the epidemiological characteristics of this novel virus. COVID-19 appears to be highly transmissible, especially even among asymptomatic and subclinical patients. 80% of patients appeared to recover with a mild symptom, but 20%, almost 20% underwent clinically serious courses, including 5% falling in critical condition. High fatality was reported among those who have underlying medical conditions such as diabetes, hypertension, and cancer, and or other respiratory illness, and the age-related fatality quite different. Highest mortality among the elderly. As shown in this slide, some of the patients who were asymptomatic and mild became rapidly aggravated, which finally led to death. So we needed to close monitor for those who are mild or asymptomatic at the time of diagnosis. So from now on, I'm going to talk about the situation in Korea. We have over 10,000 cases and around about 230 deaths as of 20th of April. Most cases occurred in the southern part of Korea, Daegu, Gyeongbuk area. It looks very busy. This slide shows the progress of epidemic in Korea. First case was reported in 20th of January. Since then, 1 or 2 cases per day were reported until 31st cases who was related with Sincheonji religious sect occurred on 19th of April. Thereafter, we observed rapid patient surge in Daegu area. So Korean Public Health Agency and the government quickly responded to this emergency state. So Korean government escalated national alert level to level 4, which is the highest one. And Public Health Agency, including Korea CDC, started massive testing for whole number of Sincheonji group that amounts to 9,000 persons in 2 weeks. And then before this surge, we did a very good preparation. Test kits were developed, and several companies, including public lab, were approved for testing. So this kind of preparation enables the Korean response agency to test, to do mass testing for the Sincheonji sect groups, huge numbers. And then this slide shows the age distribution of confirmed cases on the left. As you see, there are younger patients, more patients among the young population compared to the elderly population. It's quite a big contrast with other countries' age distribution, which have more cases among the elderly, but we have younger patients. And then the figure in the right side shows the case fatality is increasing with the age. So we observed almost 20% of fatality rate among the elderly aged 80 over. So in this slide, I'm going to summarize major routes of transmission of COVID in Korea. This route appears to similar to other countries' experience. The first one is a mass gathering place, such as a church, and Shincheonji crust also started in the religious mass gathering. And second is the healthcare settings. We observed many clusters in hospitals, and including the long-term care facilities. Yeah. And then many small clusters in densely populated workplace, such as calling center and the gym. And we also observed many cases transmitted in the family living together. But we have still some community level spread with no epidemiologic link. No epidemiologic link means we don't know who the patient come from. Is reported to be around 6% currently. It means that there are there are undetected cases in the community which will spread the virus to other people who don't have immunity to this virus. From now on, I'm going to let me explain the response strategy in Korean government against the COVID-19. As you see in this slide, the ultimate goal of public health response against the COVID-19 is flattening the curve, minimizing the health risk of patients through reducing the speed of spread and thus maintaining the function of a healthcare system of a country. This slide shows the key factors contributing to the efficient control of COVID-19 outbreak in Korea. It can be summarized like this. I think there are 5 key factors in the control of COVID-19. So one is preparedness. We did prepared after MERS, and then we did testing, tracing, and treatment, and we applied some non-pharmaceutical intervention through civic participation. Let me explain one by one. First of all, for the preparedness after MERS, I have to say two infrastructure we have. We have a public health infrastructure, about 250 public health centers of local government nationwide. I think these centers, this organization, and the manpower of these centers can be said as a basic backbone coping with the public health emergencies. And then we have universal health coverage, which enables anyone to take tests and to receive treatment without any concerns on financial barriers. Public health response perspective, after MERS, we tried to reinforce infection control in hospital, and we did strengthening the role and function of Korea CDC, and we recruited epidemic intelligence service officials in central KCDC and local government as well. We established infectious disease control center in most of local government, and year-round FETP, field epidemiology training program in every county was implemented. Second is the mass testing for early detection of cases. Since COVID-19 was reported to the WHO, we quickly prepared and responded to this new disease, applying mass testing for suspected patients and the patients under investigation. We have 118 testing facilities and about 600 screening stations nationwide. Thus, once the biospecimen is collected, the results were reported within a day. This slide shows the drive-through and the walk-through screening stations. The number of testing increased with the progress of the epidemic, resulting in a cumulative number is over 500,000 tests. The positive rate is around 2%, which means that we are doing quite a lot of testings. The figure on the left side shows the snapshot of testing per capita. So per 1 million, we did much more testing compared with other countries such as the United States, Japan, and United Kingdom. But the testing per capita changed in April. Italy, United States, and the United Kingdom started to test more compared with March. This slide shows the general guideline for testing. But there was we have some guidelines, but there are no restriction for testing at the doctor's order. Regardless of this guideline, we aggressively tested some high-risk group, though they did not manifest any symptoms. So we tried to find out asymptomatic cases in the community and in some high-risk facilities. And we did, we also did actively trace those who are closely contacted with confirmed cases in order to detect early potential cases. And this kind of tracing was done by EIS officials from Central KCDC, local IDCC, and public health centers. This shows the contact tracing strategy in a stepwise approach. First, official at the public health center of each county initially interviews the whereabouts of the confirmed cases. Second, the EIS official at the local government and or KCDC performs in-depth re-interview and collects the objective information on their routes, whereabouts, through reviewing medical records, phone location, GPS, and the credit card use, even reviewing the CCTV in the place the confirmed cases visited. Finally, the EIS officer determines whether they are close contact or casual one. Once they are classified as a close contact, they are requested or urged to stay at home for 2 weeks to monitor the symptom development. So, and then the treatment for the confirmed cases was also given efficiently to preserve the healthcare facilities function. Actually, we suffered a shortage of healthcare capacity in the early phase of Daegu, Gyeongbuk area, Sincheonji surge. From this crisis, we learned a lesson, and we developed and applied triage system to assign patients accordingly based on clinical severity. So ICU, intensive care units, were assigned for the patients in the critical condition with the severe symptoms, isolated beds in hospital for mild to moderate symptoms, and community treatment center for the rest without any symptoms. As the community level transmission becomes apparent, non-pharmaceutical intervention were applied for all citizens. So the public health agencies urged to wash their hands, to wear the mask, and to avoid crowded spaces. And then effective social distancing measures without imposing harsh lockdown, which was observed in China and other countries, helped to control the virus in Korea. This slide shows the mobility trend provided by Apple. As you can see, the overall impact of social distancing measures imposed in late February, just after the Sincheonji surge. So we can observe the decreasing of social mobility up until recently. From the local government, we received similar data on the decrease of social mobility in early March. They are reporting 70% decrease of social mobility in Daegu area and 30% decrease in Seoul area. But this graph shows the community mobility report provided by the Google. It shows that the decrease in social mobility is recovered recently. So for the parks and the grocery pharmacy, is almost recovered to the baseline level. And this slide shows the reproduction number, which means how many people on the average are infected from uninfectious person. R over 1 means that the spread is aggravating, but R under 1 means the spread is diminishing. By April, R was reported to be 0.3, which shows the outbreak appears to be under control in Korea. So from now on, I'll talk about the exit strategy in Korea. Without harsh lockdown, Korea seems to control the virus so far. There may be many factors contributing to this efficient control, which was already mentioned in my talk, except the healthcare professional devotion. Their work should be greatly appreciated in this epidemic period. But many experts are saying that it is too early to normalize the social life in Korea. This graph shows the 3 pandemic waves for Spain influenza in the United Kingdom 100 years ago, as you see, there are 3 peaks during 2 years, especially high peak in the winter season. So we can bend this curve through containment strategy, including social distancing measures at this point, but we need to prepare for the risk of resurgence following the lifting of interventions. Yesterday, both directors of Korea CDC and United States CDC as well warned that second wave will come in this winter. And still there are many uncertainties in COVID-19. And for instance, 30% of patients are reported to be asymptomatic at the time of diagnosis, according to the Korean CDC. In the recent study conducted in California, the infection is much more widespread than indicated by the number of confirmed cases. Even worse, Dr. Ben KOHI at WHO said there is no evidence an individual has immunity or is protected from reinfection from first infection. And in the recent paper published in Science Journal, even in the event of apparent elimination, this virus surveillance should be maintained since resurgence in contagion could be possible as late as 2024. So now the Korean government is preparing for transition from strong and moderate level social distancing to sustainable and softer distancing while maintaining everyday living. Actually, there are detailed guidelines for personal and community level distancing measures. For example, the public facilities are supposed to reopen sequentially based on the degree of risk. Park will open in the first place, next will be museum, and then sports camp, things like that. But Korean Epidemiology Society proposed there are few key factors to be considered before transition, which lifts up the social distancing in Korea. First one is we need to enhance capability of KCDC and Korea government for the strategic analysis and response policy decision on the emerging situation, especially in the winter season. And then we need to prepare healthcare capacity to cope with the patient surge based on possible scenarios. So we need to build clinical governance for rapid triage system, and we need to reshape the role and capabilities of public hospitals. And then third, we need to establish infrastructure for public health surveillance, monitoring for early detection of community clusters. And then we need to prepare public health preparedness clinics to maintain regular function of healthcare facilities. We also need to build operational capability and cooperative governance between central and local government for rapid response to public health crisis. Finally, we should do closer surveillance for high-risk facilities, such as long-term care facilities and nursing homes, which are expected to source of a second wave. Other experts globally call for a responsible lockdown exit strategy. They are proposing that social distancing measures should be maintained, diagnostic capacity should be prepared, and manpower and procedure need to be implemented for systematic tests and contact tracing. So a few days ago, WHO warned that easing restriction is not the end of epidemic in any country. As many experts agreed with WHO said. So we have to say that it ain't over until it is over. It's time for solidarity to combat against this virus. Thanks for your attention.
Thank you. Okay, thank you for your presentation, Professor Kim. And actually at here, I hope all of the participants to activate your camera in order for the center can have a look of you. And please change the nickname into your official names. It means your registered name because we need to have information of yours. Okay, and please raise your hand and say hello to everyone.
Hi.
Okay. You're okay? Like this? Okay. And Professor, you prepared? No? That one presentation is left, the last one. I need to know if Professor, you is it connected?
Yes, I mean.
오셨어요? Okay, we will go to the third presentation of this web seminar. And I will introduce Professor Yu to the participants. And he's a medical doctor of Suncheon University Hospital medical professor. And he's been doing lots of works on official development assistance field. So I think many of the participants already met him. 하실 수 있죠? Okay. Is it connected?
So we try to, a second please. You can see my presentation?
Yeah.
But still, I can see your profile.
Okay, first of all, it's nice meeting you. For all of the participants from all over the world. So this is my honor to have a present about the COVID-19 in current issues Korea. So I believe the God save you, all you and your family members are fine. So you can hear me and you can see me.
Well, just a moment, please. I think that the video didn't go to your center. information.
본인이 슬라이드 쇼.
나오는 것 같아요. 오케이. Well, you may start. Professor, you may start.
So, okay, may I start?
Yeah. Yes.
Yeah, so the current issue is COVID-19 in Korea. This is my responsible. I'd like to start it. First, introduction. You know, Korean government is receiving many inquiries about Korean response against the COVID-19. They asked us, how did Korea test more than 300,000 people? How did Korean control COVID-19 outbreak within a month? And what are Korean secrets in the tracking in COVID-19? So, response on the Korean government, you know, we have a center, Central Disaster and Safety Countermeasure of the headquarters, and headed by prime ministers, double down in government response against COVID-19. So, which means this is crisis, we are preparing a special equip and groups will responding to properly. So, as you see, the many times in this curve, so because of daily number programs and Chincheonji religious groups, and they are, you know, make the spreading the unrecognized infection in the community. That's why it's like a, you know, amplified. It's too much. But finally, the curve is cut down. So now this is 2 days before. Unfortunately, today we are complete 240 people are dead, but just over 10,000, and then we are slowly goes down. So this is the kind of we need understanding why it happening to Daegu Gyeongbuk province more. Because of we believe that the tracking the patient is came from the China first, and the certain religious meetings, and then they're spreading all the community, the Daegu and the Gyeongbuk. After that, our proper response in the blood can help. That's why it's not spreading the other near the province. So these days,
저기 나한테 한번 주고 내가 말씀드려야지 안 될 것 같은데. Okay. Professor Yu.
yes.
Professor Yu. Well, I think that your slides was unable to be shown for all the participants. So how about starting from the first slide again, and please make the computer system slideshow.
Now you're seeing my presentation?
Well, we can see it, but you need to choose the content, slideshow. Because the screen was still 어떻게 해주시고.
I'm sorry to speak in Korean, so just a moment, we have some technical problem. 유 교수님, 지금 슬라이드 화면이 슬라이드 쇼로 하는 화면이 공유가 안 되고 있고 그냥 슬라이드 쇼 전에 있는 편집 화면이 공유가 되고 있어가지고 우리는 계속 첫 번째 슬라이드만 지금 보고 있어요. 그래서 슬럼 선생님 그 공유를 하실 때 스크린 윈도우를 몇 개 선택을 할 수 있을 때 슬라이드 쇼를 하시는 거를 공유를 하셔야 돼요.
지금은 어떠세요?
한번
슬라이드를 바꿔보시죠. 예, 오케이. That's good.
네, 그리고 유 교수님 조금
네.
천천히 하셔야 돼요. 영어가 네이티브 아닌 사람이 많아서 조금만.
네.
네, 0.5.
움직이나요?
네, 이제 보입니다. 감사합니다.
네, 알겠습니다. Hello again, everyone. Sorry about the technical issues. So let me start from the beginning. So, we have been asking from the many people of how did Korea test more than 300 people, and how did Korea control the COVID-19 outbreak within a month? And what is the Korean secret in tackling the COVID-19? Actually, Korean government will establish central disasters and safety countermeasures the headquarters. After that, we are handling properly in the crisis. Because of the Shincheonji religion groups and kind of special conditioning Daegu city and Gyeongbuk province, that's why as you see in the middle of the slide, there are some amplified patients, a lot, but these stay under the control. Unfortunately, this is the today before. Today, 23rd April, now, we have 240 cases are the victims caused by COVID-19. But after the 10,000 confirmed cases, and then they are smoothly going down. So this is the map of the South Korea. You can see Gyeongsang Bukdo province 1,361 and Daegu city is 6,835. Why did it happen? Because probably they want the who are infected from the overseas and who is the contact with the religion groups meeting, and then they spread into our communities without symptoms. That's why it's the great outbreak so quick and anyone who are contact. But right after we recognize the patients who are from the beginning, and then we are tracking and blocking, and we can do now more stable than from the beginning. So this day, less than 50 confirmed cases are every day. Even these days, less than 10. So dramatically, it is coming down, but we are still watching. So this is the main how Korea health and the quarantine is better. Let me say 3T: testing, tracing, and treating. First, this is one of famous, like it's not McDonald's, because as you know, the McDonald's, they have the drive-through, but this we doctor from Incheon, he is an infection specialist. He suggested from like a McDonald's style drive-through, and then we also make it walking through. The patient does work, and we are testing. So that's why we can do the faster response the requirement of the community. Also, this day, so the pooling system also we are now doing, which means 10 suspicious people we are taking the collected samples with the test to the real-time PCR. If the 10 persons, the sample come in the negative, 10% are free. But if you found it is coming the positive, that time we can do one by one to looking for. So it helps the save the time and the mass of the people who are suspicious. We do the test more quickly. So test center from today, Korean government say we are closing down of the test center. But still we are working. For me, since late of the February, every Sunday I work volunteering in our hospital for quarantine center for COVID screening. In the middle of March, I do around 50 to 60 patients every day, but these days less than 10, pretty much less. So how we tracing COVID-19? Actually, since the closed camera in everywhere because of security reason, we can looking for the movement line of the patient. Also, as you know, Korea is one of the high tech of the IT, so everybody have the mobiles, and we can looking for how people are moved. Is it GPS databases? We are asking. So I am working as like a clinician in the hospital. Well, not only doctors, nurses, all hospital workers, and asking to get patient travel history from the gate control. Patients should announce at least 3 times how they are treated, their symptoms, like who have coughing, who have a fever, and who are visiting the certain area. We are checking out, and then we are screening the patient who have to go to corona test, or we attend in the normal way. Other one, KIRA is the Korean Health Management System. They provide the DUR, drug utilization review systems, and also international travel information systems. That's why after we can recognize how they get treated and where they're being. For me, I'm traveling back to Korea from the Paraguay. It was 14th of February. After that, my traveling history is on our system. I can check, which means if I'm doctor, but if I do as my patient, other doctor can recognize me. Oh, Mr. You are being Paraguay. So everybody knows where I'm being. Also, we give them to self-quarantine questionnaire and we can get a report. So this is the patient management system. The treatment-based, secure the bed for the hospitalized, providing healthcare steps, and managing medical supply and development, which means first, dengue, jungle province, it was kind of crisis because patients come same time, too many, we cannot handle it. That time, governments and doctors, medical association secure the bed for hospitalized, which means normal bed transforming as like only for COVID-19 patient. So in general patient, they're away or they're visiting another. Also, in Korea, we have the volunteer doctors, but also doctors under Army's medical system and the public medical doctors, the government organizing and the redistributing to attend patients who need it. So, from the beginning, I told you how Korea responds to pandemic using ICT. ICT law is very important because of the first, we are very used to this word, social distancing. But social distancing is not only the distance actual, the patient or people on people. We are a little bit far all the way, but how we can communicate. So actually, this is my mobile. Now it's not many, but in the middle of March, I got the message every single minute. For example, patients is recognized here by city hall. Patient recognized in Apogo office. The patient recognized from certain area. So everybody got the message, the government distributing, we are understanding, better to don't go there. And recognize us all the way, please don't be via mask and the people are at the same place. Because message teaching us and recognize us to how we can do social distancing and how we can get the information where are the patients, where patients being recognized, how we can avoid the visit to certain place. Also, as we are now, we do the more smart working is a social distancing. So, Suncheon, we have 4 different regions in the hospital, but once in a week, we have a meeting, the head persons, like directors and the manager of the hospital, before we outbreak the COVID-19. But these days, because of the region of the avoid the face-to-face, we do the conference like this. And we can communicate from each other. I have 3 children, so my big boy in the middle school and the 2 youngest in primary and the kinder, they at home, they are a little bit boring, but Korean government and the school, they provide the contents for face-to-face or the learning material system we are opening, and we do. It's a kind of homeschooling, but this is another, there are no choices actually. Until the finishing of this COVID-19 in Korea, we are providing remote education. Also, many people have a question how we can handle it. From the beginning, it was the line was busy and jammed, but we are providing one telephone number 1339 or 120. We are helping them how to handle it and how to see the doctors. At the same time, as me, some people cannot come to hospital, the reason of the COVID, but who have to take the medicine, the reason for high blood pressure and the diabetes, who have to maintain it. We are remote medicine targeting system. They come to us, we are conformed, and the credit card open for the financial supporting. Then we send the packaging or the passing all our documents to the pharmacy. The patient is not necessary to visit hospital. They go to pharmacy directly and they pick up the medication. This is what we are doing now. This is the kind of very, very interesting predictive research and spreading of the COVID-19, which means if you use the web, we can see current situation all over the world, or South Korea and Republic of Korea, or where I'm in. For example, the second of this, if I stand on the subway station and I'm on the web, they tell us where we found the patient there are and where is the kind of area is dangerous. So this sharing data help us, we can be avoided. So I believe you're expert how to do, but let me help. We do take the sample of the Corona-19's RNA, and then we are extracting and amplify at least 35 times, and then we can conform finally. But these days, in Korea, it takes 6 hours after take the specimen collected, but I believe time is getting shorter. As you know, rapid kit is not approved yet in Korea because the sensitivity is only 70–80% for the vaccine. But real-time PCR, the sensitivity is more than 98.3%, which is to help us to help the people. So this is kind of the interesting. How Korea to make the diagnostic kit and set so fast. Actually, after the 2015, the MERS 2015 MERS coronavirus crisis, Korean government and Ministry of Health, they supported to, this is mean SME, mean small, medium-sized enterprise. It's not big like a Samsung. You can see CGen, Surgeon, ST Biosensor, which is a small, medium-sized enterprise companies. The government supported to invent this kit, and they encouraging to the import. That's why Korea we can get it more faster than others. Also, we are tracing with the patient kind of pack of the, we can say the PACS system. So the pictures assessing the communicating system help patients are remote. For example, patient in Daegu is Daegu from the Seoul. It takes around 3 hours or more than car driving distance. But if we catch the finds the image of the X-ray or the CT scan, we open to the another expert in the another city like the Seoul. We can share, and finally we give the opinion to help the treatment. So this is very funny cartoon. I prepared driving through and walking through. And this is the self-diagnosis app, which means we are two. If you got a fever more than 37.5, you have a coughing, you have a sore throat, you have the kind of the difficult to breathe, we are self-testing, and this is where suggests how to go. When after the ceremony, and this act how where you can go, so and how you can connect it. But people ask us how Korean government and the control center they catch the infection number, because some countries they re-announcing the number of the deaths and re-announcing the number of the confirmed cases, but we have from the beginning here up and all the hospitals are connected under by Korean insurance. So I like to say under the KCDC you can find it HWell NHIS Health Insurance Review and Assessment Service. They have it all collected our attendance cases number. Real time they can calculate it and inform to the people. Actually, every day, nearly every day since last week, 2 p.m., Dr. John and Dr. Kwon. Dr. John is famous. Dr. John Eun-young, she's the head person of this group. And Dr. Kwon also they announcing every 2 p.m. after they get the collected data from this system. And we make this. So, yes, research facility drug need proposing first virus distribution and cultivation, and we are moved to the drug screening to identify the candidate drug efficacy test cell, and then we are informed to the hospital. So these systems mean we can looking for what kind of drug or the medicine or efficient to the patient, because now many medicine are the under testing. We can share the experience because some doctors say cholesterol, I believe you know, for the AIDS, the treatment for the HIV. Some people say the cholesterol is better, but some people say remdesivir, as you know, the medicine for the Ebola, or hydrochloroquine, as you know, hydrochloroquine for the malaria. But sometimes it's a combination of serum transfusions. So some successful cases we have it for each hospital in the field. But that time we collected real-time data, and we can isolate it, and we suggest the best way to the treatment. So, what is the best for the treatment for COVID-19? Still, we don't know. And we are using, we can say, old used drug like the cholesterol, remdesivir, and the hydrochloroquine we knew already, and we apply in the photo new step. But probably they are due and very matched to one problem we have it. So that time we looking for drug candidate. And drug candidate, it helps the first staging of the medical challenge. And then if they are very efficient, we can try the second round either for animal challenge or sometimes efficiency for the human bodies. So let me remove the middle of this. This is a kind of one step, data generation, data provision, and this is the one I'm talking about. Where mask? Where's my mask? So sorry, mask is necessary for the living in Earth, because it's very difficult to find the people who are no wear mask in the street. But issue is Korean population around 50 million, but if we change for every day, we need 50 million per day. But Korea we are producing now around 17 million masks a day, but how we can contribute? So that's why we say public mask, which means people, they can buy themselves for the pay and buy the mask. From the beginning, we don't have a mask in the market, but now it's stabilized, we can buy. But, you know, price is the matching with the supply and consumers. So now, just price of mask is a little bit higher than usual. But this is, we can say, public mask, Korean government say, and we are distributing with the proper price. So the price is for one mask, $1.5 value and less. We can buy 2 masks a week, depending on the year we are first. I'm born in 1974, the end of the Monday to Friday. So I'm born in the fall, which means my day is the Thursday. Thursday, I can go to pharmacy or post office or government, the Hanaroma, I can show them my ID card. I can get it 2 for the week. If I miss the day, we can go to Saturday or Saturday. That time we can get it. So anyway, Korean people can get at least 2 new masks at the proper price a week. So this is a contributing system. So yeah, this one, innovative. These days, many companies make COVID-19 related information. They provide one economic and the financial measure. As doctors, we are fighting against COVID-19 as treated and prevented, and the work is like quarantine. But issue is economic and finance. Why? How we can prepare all the and how we can distribute the medical staff, how we support the public hospital or hospital which is attend the COVID-19 patients. Because until now, most of people are treated it free in Korea because this is kind of the crisis. That's why Korean government preparing some principle, and we preparing of the budget. Also, we are preparing for current exchange program with the U.S. and we are depositing the National Bank program. It helps for our Korean society financially stable. So because people are getting anxious and the market is upset, stock is down, and the pricing and the exchange rate of the dollar against the US dollar is higher, which means economically collapsing. That time, finally, medical attendance system was collapsed. That's why Korean government is preparing for financial program. And then I told you that we prepare currency swap exchange with the US and preparing the finance part. And we are now final stage to emergency relief payment for all Korean people. It's not confirmed yet, but today is Thursday until Tuesday of this week. 70% of Korean people can be get emergency relief payment provided from the government. But recently, Korean government will be sure to give all Korean people get emergency relief payment. But we are also high salaries people probably will donate it back to government or other groups. But we are talking about not only the 70%, the household with income or below the top 30%, but anyway we are prepared or 100%. So this is we are discussing about it, and we do. So this is my honor to exchange our knowledge, our experience. First, so Korea is a speedy and swift action because decision and leadership is very important. Because I don't want to mention and I don't want to blame any leader in other countries, but leaders lose their tempers and lose their direction. The people are suffering. But these times, Korean government and the leader groups and the speedy and swift action help to closing the COVID-19 crisis now. The second action be the summarize the treaty. I told you, yeah. And this is the testing and the tracing and treatment. You know, Korea, anyone who wants to test, we can do test. And Korean ICT and CCTV and tracing system can found it to the chain of the infections chain, and we found the people and sent to the treatment. And we are focusing high-risk groups, and we found and sending the high-end treatment systems, and we fight against COVID-19. The third issue is PPP, public-private cooperation. And I'm so appreciated the Korean people's awareness and knowledge and follow the government regulation. This day, you know, strong social distancing are now or the change step down, but still people are wear masks and try to keep the social distancing and washing their hands, and they do cooperating whenever they enter the buildings or certain place for quarantine check the body temperatures, and we are asking the self-questioning quarantine system too. So that's why we are, until now, we are well. I hopefully finishing the COVID-19 overall. Anyway, what we want to do personally, not only WHO, because I'm not expecting more than WHO in this moment. We are Korea and United States, China, Japan, many countries can be, after the stabilize them, we have to looking for the country who need our experience of tech, which means, you know, at least the test center for COVID-19, or we can share how we can operate the hospital and the COVID quarantine center, something like that. So I volunteer the volunteers doctor in KOHI, Korean Overseas International Agency. I believe the KOHI and others, the Korean government organization, we are willing to and happy to visit some place or certain countries who need our experience sharing and knowledge sharing. We are ready to go. So thank you for your attention. So from the beginning, technical issues, that's why it was not smooth of the beginning. But anyway, I appreciate your attention. Thank you very much.
Thank you, Professor Liu, for your enthusiastic presentation. Okay, now we will going to have a Q&A section. So, because all the three presenters reviewed and prepared their answers before our web seminar, so most of the questions already been answered. But that here, I hope that some participants from many countries can ask their questions. Even though we cannot cover all the questions, but some of the questions might have answered it here.
First, I have questions already.
Okay. Who are connected? Yeah. Well, I think all the three presenters are here, still participating for this web seminar at the moment. So, well, the first question can be made by Powell Kanina from Kenya. Good morning.
Good morning. Thank you very much. I'd like to start by thanking the three presenters. The presentations were very informative and very clear. Thank you. So my first question is about the demographics of COVID-19. We know from the first presentation that there are 3 deadly coronaviruses. We had SARS, we had MERS, and now we have COVID-19. All these 3 viruses seem to have a bigger effect in the Northern Hemisphere than in the Southern Hemisphere. Africa seems to be spared. We do have cases of COVID-19, but not as many as in Europe or the US. Do we think that this will escalate in the future?
Well, how about Professor Kim Dong-hyun? Can you answer for his questions?
What was the exact question? So you are asking how the situation will happen in Africa?
Yes.
I see. Yeah. I think Africa needs to prepare for the coming epidemic of the COVID-19, since there is no immunity among human population. So we don't think there is any immunity among African populations. So in the real, in the future, the virus will spread to Africa as well. So any countries in Africa should start to prepare the epidemic as soon as possible. I think the time is very important in preparing this COVID-19. So as you see in the mass fatality in the United States, they just 1 month late to prepare this epidemic.
Thank you very much. My next question is about the R0. How many people can one person who's infected with COVID-19 affect?
Yeah, actually there are several reports about R value from China and any other countries. I have seen one meta result reporting R0 is around 2.5. I remember that. But in Korea, in the initial phase, R0 was reported around 7, but it decreased with the epidemic progress. Currently, as shown in my slide, R0 actually the effective R is around 0.3, which is good to control this outbreak.
Thank you very much. Those are my questions. Thank you.
Yeah, well, among the questions which were submitted was one of it is, well, I think it came from an African country, how to balance between poverty and lockdown, and should we go for herd immunity? I think this question can go to Professor Liu and also Professor Kim too.
Well, my personal opinion about the lockdown, the lockdown is the kind of basic quarantines way. So for Korea is a trading country. Trading countries mean we cannot lock down. Even from the corona, if we know about COVID-19, we can be control of the passengers from the airport and the harbors. But you know, Korea and China is closed, and the number of people are the visiting and the go and there. So lockdown is actually impossible. But some countries like Mongolia is there are no sea, and the airline is limited. The country like Mongolia can be lockdown is one of the good choice to be avoided from the overseas way. So there are no right answer, and this one, no one can say who right and who is wrong. But Korea was we are closing to the gates into the Korea. Now, not 100% closing, nearly very little now, but 100% lockdown is impossible. So it depends on the countries. But like Fiji or Sri Lanka, it's an island country. If they don't have any cases come from, they can do kind of the lockdown can be one of the choice. But as in case of the Sweden, so the country they do it's like a herd immunity action. So still depend on the country's concentration, they can choose the way.
Yeah.
Thank you for your question.
Professor Kim Dong-yeon,
Okay.
one question mentioned about the herd immunity. Yeah, what is your opinion on that?
Okay. I like to add some for the issue on poverty and lockdown. It's a really big issues to be tackled globally. Actually, once the community level spread starts, there may be no way to contain this virus except lockdown. But lockdown means poverty among the poor, especially in the low and middle income countries. Actually, some countries in Europe and the United States try to support their citizens through stimulus package to solve this kind of poverty problem in their country. But for the most of the country, for the low and middle income country, the role of government may be limited because they don't have enough resource to support their citizens. So this is we should start to support. We need to make some coalition, or we need to start to support those countries with international solidarities. So I think the WHO or other UN-related organizations should start some initiative to support the citizens living in that countries. Okay. Let me move to second question. Herd immunity. Actually, some countries tried to challenge the herd immunity because there is no vaccine and no treatment to this virus. And then in the initial phase, this disease, due to this virus, may be asymptomatic or may mild symptoms. So Sweden and United Kingdom, Japan, and even in Sweden expected herd immunity maybe can be strategy approach to this to combat this virus. But as I said just before, the R lot is 2.5. If R lot is 2.5, we have to get the herd immunity, 60% of the total population should be infected. So mathematically, among them, 5% will fall into critical condition. So if so, 3% of total population may fall in the clinically critical conditions. I think there is no country to tolerate this kind of serious condition. So herd immunity, very difficult to challenge it. So we recommend to try to contain this virus as much as possible, and then impose the social distancing as early as possible. And then we need to start to initiate international solidarity to support some countries' efforts.
Thank you so much for your good opinions and answers for the questions. And the next question go to, well, we can get questions from Sri Lanka, MDA Krishan. Yeah.
Good evening, Professor Kim.
Yeah.
And good evening to you all. Mm-hmm. I just have two questions. First one is, do you have any model developed to forecast when this pandemic will end globally? Another thing is there any maybe research or something that the coronavirus is affecting, I would say, hot countries, that means tropical countries, are not affecting much as your area? Those are the questions.
Well, I'd like to ask the presenters, are you clear with his questions? Professor Liu, is it okay for you?
Should I repeat it?
Yeah.
I can answer for one of your questions.
Yeah. Mm-hmm.
So the character of the coronavirus, usually high temperature and humid, rate of the transmission is low. But the problem is, like Singapore is one of the good examples. Singapore is like an air dome because everyone in the under air conditioning and it's clouded, which means not only we can say the tropical area, but there are special conditions under the air conditioning and clouded in the living condition and near world the temperature is a little different. So that's why we cannot say the usually tropical area is hot and humid. That's why it's viral, especially like the corona, something cannot spread well. I've been to Saudi Arabia, diving experience of the virus coronavirus, but it's Riyadh, but it's very hot. It's the capital of Saudi, but Jeddah is the same temperature like the Seoul, very good. Jeddah is the second city of the Saudi Arabia. Most of the MERS coronavirus victims, it happens every year from the Jeddah. And they transmitted to the Riyadh. Also, Saudi Arabia is very hot. That's why everybody lives under air conditioning. So which means, traditionally, coronavirus cannot be spread to make the big cluster patient. It cannot. It's difficult. But this convenience, like air conditioning in the dome, can make the same condition like now. So that's why kind of ridiculous, the controversial thing, no air conditioning and just natural leaves, probably better. But we are used to having the air conditioning. That's why Korean government also having the know about it, because getting warm and hot, because Seoul is the 36, 37 Celsius, humidity more than 78 is very hot and annoying. But people in the world, so finally, we are still saying the risk for the coronavirus. This is my answer. Thank you, doctor.
Thank you. And well,
Thank you.
what is your opinion, Professor Kim Dong-hyun? Yeah. For the first question.
Okay, so I think the first question was the when to end of this COVID-19 outbreak. My answer is nobody knows. So the virus knows. Yeah, the virus knows, but actually until the vaccine development, the virus will circulate in one area to another area, on north part and south part, circulating. And so this is novel virus, and we don't have immunity as a human to this virus. And and then
The connection had some problems. 좀 얘기하시는 거 아닌가? Okay. Well, Professor Kim, we were unable to listen to your voice for a while, so please.
you cannot hear my voice?
Yeah. About half of your answers. So the virus knows, and afterwards, from
I see. Okay, I'm sorry about that. This is a novel virus, so we human population don't have immunity to this virus, so it will circulate this place to another place, from north to south, until the vaccine develops. So we have to prepare for the outbreak in the long time. We have the long time strategy, long time plan to combat this virus. I think it will not end in a short time. So we need to prepare or set the strategic plan to combat this virus based on the infrastructure of each country. So it's time to start make a country level plan, strategy against this virus.
Yes.
Please do not expect it will end in a sooner time.
Yeah. It's a good answer. And well, I got some messages that there are many medical doctors who is working for KOHI at KOHI. So I'd like to have questions from KOHI doctors. Well, one of the KOHI doctors. 누구요? Who will be connected? Paraguay or 병철? Who? KOHI doctors. No?
I'm not a KOHI doctor, but I have a question.
Yeah. You may continue.
Okay,
Question.
I wanted to ask about the relationship between the current prevalence of TB that you have in your country and the prevalence of COVID-19 among those patients that are already susceptible to TB in the country. Did you actually extrapolate the data to check the relationship between the two diseases? What is the risk like among people who already have got TB within Korea as compared to the COVID?
Well, we were unable to watch you. So I think, would you please repeat your questions again, one more time?
Okay, my question is on the relationship between COVID-19 and the tuberculosis situation in South Korea.
Okay.
Like you have patients already that are suffering from tuberculosis that you have in the country. And what is the prevalence like among those patients who are suffering from tuberculosis? Because when you look at COVID is also a communicable disease like tuberculosis, and the same indices that can be used for transmission from TB can actually be factors that can actually be leading to the spread of COVID when you have a human-to-human infection. Is there an analysis that has been done in terms of that relationship?
For this question, well, I think both of the two professors can give us answers. Well, Professor Yu first. Yeah.
So, actually, the now-audio condition is not there, but anyway, I do answer according to my understanding. Korea is the biggest tuberculosis patient country in ODCA.
Yeah.
Because Korea is still, there are a lot of the tuberculosis patients. Active, also latent tuberculosis too. But COVID-19 and the tuberculosis related research I couldn't find yet, but I believe usually COPD, chronic obstructive pulmonary disease, COPD or chronic lung disease patients are most vulnerable, the patients with COVID-19. So I believe COVID-19 doesn't make the tuberculosis get worse, but patients under the tuberculosis treatment or had it before, it could be the high risk group for the COVID-19. This is my answer.
Yeah, and what about you, Professor Kim Dong-hyun?
Me? Actually, I have an idea about the prevalence of COVID-19 among the TB patients. I think if we can review our data collected in the COVID-19 outbreak in Korea, actually we are still analyzing the data, clinical data. Yes. We can see what kind of impact of COVID-19 infection on the prognosis of TB patients, or vice versa, the impact of TB on the progress of COVID-19. We can follow the clinical course among those patients. But at this point, I don't have any information about that.
Yeah, thank you. Well, I don't think that we have plenty of data to analyze so far, so that sees the problems. Well, the last question might be this one. I got a message from a doctor of Malaysia. He's a clinical doctor. And what is the major difference between Korea and Singapore? That outbreaks and control pattern is different. I think the way how Korea dealt with it and Singapore dealt with it, one might be the differences and controlling process. Well, what is your opinion, Professor Kim?
I think the Singapore is reported to succeed in control the outbreak from the beginning of this pandemic. So they closed the board from the China, and then they tried to contain the virus through a similar strategic approach, such as testing and tracing and treatment. So, but in Korea, without border closure from China, in many regions, so we experienced a very big surge in some part of the Korea, but we did succeed. We tried to bend the curve, so it appears to we are doing good job until this point. But in Singapore, they lifted their social distancing measures too early. So they are experiencing second surge in their country. So the number of cases is sharply increasing in Singapore. So that gave the Korean public health authorities big lessons. So we are very, very cautious in reopening our society, because we don't repeat the Singapore's path. We don't want to follow the Singapore's path.
Yeah, and Professor Yu.
So I was in Cambodia first week of the February and the end of January, 2 times. 1 week I was there twice, because I visited 2 times in Cambodia in 10 days. That time we found that the kind of beginning of the corona crisis is happening in Cambodia. But why I'm telling you about Cambodia? Cambodia is a country never have experienced the infectious disease. But Korea and Singapore, we have experiencing from SARS and the MERS. 2002, Korean government and the Singaporean government have experienced. Fortunately, not many happened. Korea was 0, but Singapore was having experience. After that, Singapore is a small city country. They're having feeling of the crisis because that kind of city extinction, which means small size metropolitan countries. It is infection the hitting. This is a kind of real crisis. That's why they're preparing the system to quarantine before. But at the same time, early of the February and late of the January, there are Chinese Lunar New Year. Chinese Lunar New Year in the Asian country is like Korea, Japan, no Japan, sorry, Korea, China, Singapore, Malaysia part. We have the whole holiday. That time, many Chinese people are visiting this area. That time, I like to say first wave. We have the first wave of this, and we depend. And now Korea is the more is stabilizing. But Singapore, they do very well, but they have been facing the second wave, second hit from the foreign laborers. As you know, Singapore is a very well-developed country, that is true, but some people's labor group, they are living together, they not control the quarantine well. That's why the second wave is coming. Probably this issue is not only for infectious disease condition, probably is social structure issues. So my answer is Singapore and Korea is we are well prepared after the big hit from the SARS and the MERS, like the heat mass infectious disease. And then fortunately, Korea, we don't have the second wave. So Singapore, we have to watch it from the second wave from the foreign labor who live in Singapore. This is my answer. Thank you.
Yeah. Well, thank you for your answers. And well, before we finish up, the last question might be from Hyung-Chul Kim. Oh, yeah. Yeah. Well, would you please take up your question?
Yeah. Nepal has 45 patients until now. However, due to the large number of patients in India, so Nepal affected India's situation. So Nepal until now, lockdown is during 1 month, Nepal got the lockdown situation. So Nepal has suffered a large number of low-income people. So because of current lockdown, they are suffered the business problem. So perhaps due to the economic problems, eventually it will unlock down. So in this case, it is likely to unlock where there is still have the problem, increased risk of local infection, regional infection. So what policy strategy can help in this situation?
Well, but I think the answer might be very difficult for the professors because, well, under your situation, the government should make the policy. Well, as it is a novel one, so I think proper policies for each countries and the strategies for each conditions should be made by the government and the medical professionals all gather together, and they have to create proper one for each conditions. And this is my answer. But well, do you have any other opinions, Professor Yu or Professor Kim?
Yeah, actually, it's very hard to answer. But as I said before, I think there may be many countries to afford to tolerate the lockdown due to the economic situations. So, as I said, the international support and international collaboration are strongly needed to such countries, because unless the virus is not contained in such countries, the virus will come back to their countries in the later time. So some countries who trying to control the virus with economic support or financial support, should try to support more to other countries to end this virus. Yeah, it's my opinion. But so the international leadership is strongly needed in this situation.
Yeah, thank you. And Professor Yu, do you want to add up some answers?
No, I fully agree about it. And I'd like to say some word. You know, this is the kind of common thing. Africa called the word, I'm hungry, no one listen. But Africa called, I have Ebola, everybody listen. You know what I mean? So it's time to be alive for one. Because this is human beings. As a human being, we have to fight against the all together and collaborate. So if some countries or some institutes found to the medicines or the vaccine should be open for court for shared for the public. So that I believe Korea and the friendship countries will do together. This is my last answer. Thank you for asking me. Thanks.
Yeah. Well, even though we are medical professionals and healthcare professionals, but we cannot make up the policy of the government. So we have to submit our opinions, professional opinions, to make the administrators to take up and choose good policies for their each countries. Well, before we finish up our web seminar, we already mailed your evaluation sheet. So please answer for that. And my conclusion is we cannot guarantee the future of the COVID-19 outbreak, but keep watching and reacting fastly and systematically can make the future of us. They can guarantee our future. That is my opinion. And well, as the time goes on, I think that we can accumulate more experience globally. And afterwards, I think that we can create more smart conclusions in the future. So under that context, our institution and MedRIC and KISTI and many institutions who cooperated for this web seminar try to open another episode of web seminar again. And thank you for the participants from several African countries like Ghana, Mozambique, Tanzania, Ecuador, Ethiopia, and many Asian countries like Philippines, Bangladesh, Thailand, many participants from Thailand, especially the Baido University, and Sri Lanka, and Lao PDR, and Myanmar, Nepal. I elapsed Luanda, and many other Asian countries, and one country from Latin, Bolivia. Thank you for your active participation, and I think that we can make more good web seminar afterward. Thank you for your participation. Bye.
잘 지내요. 경찰도 사랑해. 건강해, 우리 만나.
잘하고 있어요.
감사합니다.
Thank you.
감사합니다. 교수 화이팅.
감사합니다. 감사합니다, Professor Kim.
감사합니다. Thank you.
이거 인물자처럼 할 수가 있어요. 여기 특징. 네. 마들로 스테이키로. 자료가 그게 대한민국에서 만든 자료라서 공자료로.
기록을